Good morning. Let's talk about suicide. Your presenters today are Bridget Carter and Tammy Amdahl from Mayo Clinic in Rochester, Minnesota. To start, I'd like to give you a brief overview of the projects that we are going to present. Ambulatory nurses take calls from patients experiencing suicidal ideation and lack resources to respond appropriately to these low-volume, high-risk encounters. We found that the majority of people who died by suicide have visited a healthcare provider in the previous month of their suicide. Our objectives for today include outlining a standardized process for assessing and responding to a patient experiencing suicidal ideation on the telephone. Secondly, to identify methods used to involve the interdisciplinary team in the process. And lastly, to provide ambulatory nurses with the resources and a standardized documentation process to empower them to care for patients experiencing suicidal ideation. Our work group consisted of 8 nurses. That was made up of a clinical nurse specialist, nurse managers, a nurse educator, and a nurse administrator. We have been meeting since September of 2017. We met with our stakeholders, which included an integrated behavioral health team, telephone operations, legal, security, local law enforcement, and social workers. The institutional telephone triage guidelines, ambulatory procedures, and educational offerings were reviewed. Based on the gaps that we identified, literature was evaluated for best practice adoption. An algorithm and scripts were developed to expedite care of suicidal patients over the telephone. The RNs were educated on use of the Columbia Suicide Severity Rating Scale, the short version, and documentation of the encounter. This standardized process was approved to be piloted in 3 subspecialty clinics with education occurring over a 2-month time frame in an ambulatory large academic medical center. We sought out 3 units that were willing to participate and who also felt that they had a higher incidence of suicidal phone calls in the ambulatory setting, excluding primary care, and ranked the frequency they had calls by weekly or monthly. When we met with them for education, several of the nurses had previously experienced a suicidal phone call with a patient. We encourage nurses to fill out the survey after a suicide phone call to determine if further resources or support are needed for nursing staff, and also if resources provided met the needs or if revisions were needed. Team touchpoint approximately 1 month after the initial education to assess further needs.
We educated our nurses on the CSSRS, as Tammy mentioned, the short version. The short version is an evidence-supported questionnaire that's used for suicide assessment. We currently have this flow sheet built into our health records, so the nurses had to be taught where to find it and then how to use it. I know this is quite small on the screen, but this was our algorithm that we had the nurses utilize to really help identify what to do when they did receive a phone call. So at the top, we had the patient identify the patient was suicidal, and then really the blue box was to make that assessment, figure out who the patient was, where they were, and then use the CSSRS. And based on the answers from the CSSRS, would the nurse put them in a low-risk category, moderate risk, or high risk? When that was determined, then there were additional steps. So if they were low risk, we offered more resources. Moderate, we piled on additional resources like social workers, or if they were high risk, we typically accessed 911, whether it was an internal process for patients that were on campus or an external process accessing external 911 as well. So our results, we ended up educating 41 registered nurses within the pilot units from medical and surgical subspecialties. The 3 pilot units were neuromedical, specifically epilepsy and behavioral, rheumatology, and medical oncology, specifically breast and brain. We did receive a limited amount of calls during our pilot, only 4. However, we did feel like we were able to test our processes. What was interesting is neurosurgery, another subspecialty, asked to join our pilot about a month later because they were receiving a spike in suicide phone calls and they wanted the resources. The additional thing that was interesting is our nurses really craved the resources so much that they wanted to use them face-to-face, even though we initially had sought out to target our nurses talking on the phone to patients. So it was certainly a fun finding that we were offering great resources to be used in more than one way. The nurses felt the education and resources provided their interactions with more support. They found that the documentation went a little bit easier when they knew what to ask. We also allowed them a kind of like a template within their documentation that helped them just kind of shape some of their additional documentation, and that was found to be helpful. One unfortunate thing was the nurses didn't realize that in the heat of the moment, it's hard to find some of your tools. And so we did realize that they needed to set up their flow sheets within the health record before they actually received a phone call. So our conclusions, really we know our nurses are our communicators. They're working with those patients, and they're certainly often the ones that are identifying what to do for that patient at that moment. We really feel like this process is using best practices. We want to test it further and replicate it across our enterprise. At this point, we're just in those stages. We're hoping to roll this out in the next few months in the entire enterprise. What we do know is that as we expand, some of the resources do need to be varied based on the location. We know some areas have more robust resources like social workers, security, that kind of thing. So we do realize that we're going to have to adapt as we continue to roll out. But we also have realized that we want to use this process face-to-face as well as over the phone. We do have to adapt some of our resources because we were targeting telephone, but I think that will be very doable as we move forward.